Hi,
We are all tight and hot. Hi,
Pratik.
Pratik.
Hi, Pratik. Good
Hello,
afternoon.
madam. Good
Yeah,
Good afternoon.
afternoon.
Pratik has joined.
Ma'am, you can
Pranam,
start.
sir.
Can't believe Pranam.
Pranam to Pratik, sir.
तुमचा टॉक आहे तर मी असला पाहिजे ना.
Thank you.
Ma'am, you are YouTube live also. You can start.
So, Pratik, since you are there, you can start.
I'm just here as an observer. You please carry on.
Just start.
Good afternoon, everybody. Welcome to today's event. This is, I think, the seventh or the eighth in the series of CCC, which has been initiated by our beloved Dr. Anju Soni. She was the chairperson for the FOXI HIV/AIDS committee, and she's initiated this very unique initiative of learning where we have a single speaker and there is a focus talk for 45 minutes to 1 hour on a single topic. There have been many stalwarts in this series who have graced this chair previously, and today we have yet another stalwart, a legendary figure in teaching over the past 3 decades who has joined us in the shape of Dr. P.K. Shah. So without further ado, I will hand over to Dr. Anju Soni to please do the honors and get us started.
Thank you, Dr. Pratik, for your kind words. It's indeed a great day. We are today on seventh episode of this webinar series, and I welcome all the esteemed guests, distinguished colleagues, and respected participants. It's a great pleasure and anticipation that I welcome you to our webinar on women's health diagnostic, particularly focusing on crucial role of ultrasound in detecting torch infections during pregnancy. Today, we are privileged to have with us eminent Dr. P.K. Shah, uh, president of FOXI 2012, our great orator. With his wealth of experience and expertise, Dr. Shah will guide us through the intricacies of ultrasound imaging techniques and their application in diagnosing and monitoring the torch infections. Torch infections, as many of you may be aware, pose a significant risk to both maternal and fetal health and well-being, uh, as long as and long-term consequences. And thus, understanding and accurately diagnosing these infections are paramount for effective management and positive outcome. In addition, we have a pleasure of um, having with us Dr. Jayam Kanam, Vice President of FOXI, and Dr. Asha Bakshi for gracing their presence, and their expertise will further enrich our understanding for this crucial topic. Today's webinar is not just an educational event, but also a collaborative effect of advances our knowledge and enhance our skills in women health diagnostics and its platform for exchange, learning, and growth. Thank you very much. Over to Dr. Sweetie for inviting the chairpersons. Dr. Sweetie.
I don't think she has joined.
She's there.
She's there, sir.
I don't see her
Maybe I can.
video. Voice
No,
is
sir,
Some
not.
of our
video.
network is a little unreliable.
So we have with us Dr. Jayam Kannan. She is FOXI's Adolescent Health Committee Chairperson 2013, and she has been Emeritus Professor, Tamil Nadu MGR Medical College, University, and Managing Trustee, Garba Rakshan, uh, Raksha Group of Institutes. And she has also been a Vice President of FOXI in 2018. We also have with us Dr. Asha Bakshi. She is uh, she has been uh, she is at the moment Secretary of ISAR, member of Executive Committee AIC, AICC West Zone, and also founder chairperson of MP IAG and MP ISAR, and she is also member of Advisory Committee PCB and DT. She has been chairperson of FOXI Infertility Committee, member ICOG Governing Council, and past president of IOGS, and also Vice President, Foxy West Zone. Welcome, Dr. Asha.
Thank you.
Please invite Dr. Shah, sir.
You want me to invite?
Yes.
Yeah, I put this thing slide of PK Shah, please. CV
Madam,
is there?
Just say a word, that's all.
Shah, I know
One
you,
line.
you know me, Asha knows, but for delegates who are youngsters,
Oh my goodness.
yeah, for the youngsters, it is not for you and me. You have to know.
You
In
no,
want
that,
sir. We
let
know
me tell
sir
you.
as a great teacher.
Yeah,
No,
Dr.
let me
Shah has
say.
been teacher of teachers and has tremendous knowledge on ultrasound. And if he starts speaking, I think 1 hour is also not enough for him. And today, Anju, you have really selected a very good topic. And I think you are everything. You are a blend of beauty with intelligence, with dedication, with sincerity. And look, what a brilliant idea you have. You have selected a specific subject, and that is infection. And in infection, now torch. And torch is such a thing which is really neglected, and especially because we have all stopped doing torch tests for recurrent pregnancy loss. So that sensitization which we had initially is all gone. But we do understand that when it occurs, then especially when the active primary infection occurs, then the infection may reach the fetus and may cause lots of morbidity and long term it has its long term implications. And many countries in the world initially had started screening for toxoplasma, screening for this and that, but slowly they didn't find it cost effective, so they have stopped it. So what I mean to say is that it is very important now only to get sensitized that such an infection can occur if a mother has fever, she has got lymphadenopathy, lots of backache, then we just let it go. Arey, koi viral hoga. But I think we have to think about it that sometimes it may be torch, and especially if these patients they undergo ultrasound, then people like Dr. PK Shah, they will tell you that how much it is important to look for the markers of these infections in ultrasound. And once you know about these markers, then you'll realize, अरे कहीं torch तो नहीं है, and then you'll start investigating. And these days, not only that you do IgG, IgM for all these infections, but there are avidity tests for each and every infection particularly. So, and you can do amniocentesis and do PCR. So many things are there where you can specifically find out which infection it is, and you treat in the early stage, or if it is very bad, you may even advise termination. Then naturally in the long term, you are doing a lot of good work and preventing the fetal morbidity and mortality. So I'm sure we have lots and lots to learn from Dr. PK Shah, and sir, stage is all yours. Thank you.
Thank you very much, Asha, for your kind introduction. Respected Dr. Jayam Kanan, Madam, Vice President 2018, Dr. Asha Bakshi, Vice President 2023, and my dear Dr. Anju Soni, who has invited me to talk on torch infection during pregnancy and ultrasonography. This CCC program of yours, Confusion, Clarity, and Consensus, I think is going to make it very meaningful for people. If you are interested in that particular topic, you join, otherwise you don't. There is no khichdi of 10 topics, so you have to select one or two from them. So I'm very happy, and it's so nice to see Pratik joining from space. Very nice, Pratik. So first of all, let me tell you that when I thought I'll talk about only ultrasound, then I realized that I'll finish it in 10 minutes. Because there are so many ultrasound findings in different torch infections, which are common. And there is nothing great to go into details of, if you really ask me. So I thought I'll cover torch infection as such in detail, along with ultrasonography, because as Dr. Asha Bakshi said, that we have removed torch titer as one of the investigations from our armamentarium for cases of BOH, bad obstetric history, because torch infections do not cause repeated pregnancy losses that we all should keep in mind. So let's see, let me share the screen. Can you see it? Yeah, Pratik, good. So we'll start with torch infection. The torch complex is a medical acronym for a set of perinatal infection that can lead to severe fetal anomalies or even death. They are a group of viral, bacterial, or protozoan infection that gain access to the fetal bloodstream transplacentally via chorionic villi. Torch means toxoplasmosis, other infections, rubella, cytomegalovirus, herpes simplex 2 virus, and other infections like syphilis, varicella zoster, parvovirus. Out of which I'll be talking about this 1, 2, 3, 4, varicella and parvovirus. Coming to first one in torch infection, the toxoplasmosis caused by Toxoplasma gondii, and it's an intracellular protozoan parasite. Infection is acquired primarily by ingestion or handling of undercooked or raw meat, especially pork, lamb, etc., containing tissue cysts, or by ingestion of food or water contaminated with oocysts excreted in feces of infected cats. Primary infection is usually asymptomatic and has mild, non-specific symptoms. Cervical lymphadenopathy may occur, or that could be ocular disease. Now that's the cat which is responsible for spread. You can have oocysts contaminating the cat litter, and if by mistake it is ingested by a pregnant woman, then you have tracheozoids transmitted transplacentally to the fetus. The same cat litter will have fecal oocytes that will go into the soil, water, and grass contaminated with oocytes. Now, if that is consumed without washing thoroughly, then you can have again a woman getting infected. The same soil, water, grass contaminated with oocysts, if they're ingested by animals and some, they will have tissue cysts containing bradyzoids in prey. And again, that goes back to cat. And this is how the whole circle continues. Acute toxoplasmosis is mostly subclinical, affects 0.3 to 1% of pregnant women with an approximately 60% transmission rate to the fetus. The risk increases with gestational age. Transmission risk increases with gestational age at seroconversion from less than 1% before 4 weeks of pregnancy, between 4 to 15% at 13 weeks, to 25% in second trimester, and more than 60% at 36 weeks onwards. Conversely, risk of congenital abnormality is inversely related to the gestation as maternal infection, such that the severity is greatest when infection occurs during the first trimester. What are the sequelae of fetal infection? The toxoplasmosis mainly affects the central nervous system and eyes, can cause a microcephaly, ventriculomegaly, hydrocephalus, chorioretinitis, learning difficulty, convulsions, spasticity, blindness, hepatosplenomegaly, anemia, rash, pneumonitis, and jaundice. The classic triad of chorioretinitis, hydrocephalus, and cerebral calcification is rare. But you have to keep in mind the ultrasound features described, which include ventriculomegaly, dilatation of the lateral ventricles, or hydrocephalus, extensive dilatation of the lateral ventricles, microcephaly, intracerebral calcification, cataract, and ascites. Magnetic resonance imaging of fetal brain should be ordered when ultrasound is inconclusive. That is a chorioretinitis, hydrocephalus, in the baby affected by toxoplasmosis, and these are the intracerebral calcifications. That's typical microcephaly. How do you find out? When you do a BPD, and if it is more than 2 standard deviations below the norm for that particular period of gestation, you call it a microcephaly. Then you can have ventriculomegaly like this. When you have a choroid plexus dangling inside, you can have a typical ventriculomegaly, the dilatation of the lateral ventricle. When the dilatation of the lateral ventricle is more than 15 centimeters, you call it as hydrocephalus. And this is how it looks. Look at the choroid plexus, okay? This is very typical of late cases of infection with toxoplasmosis. Intracranial calcification you can pick up very easily on ultrasonography. And then the lens that we normally see when we're looking at the eyes and the orbit, it is opaque. Both the lenses are opaque, and you know that you're looking at a congenital cataract. You can have the liver and spleen almost occupying the whole area of the abdomen when you have hepatosplenomegaly. And then obviously fluid around liver and other organs will tell you that there is presence of ascites. Now, all these things will not be seen in a given case at a time. But these are the things to be kept in mind when you do ultrasonography in a suspected case of toxoplasmosis. How to diagnose metal infection detected by serological test should be followed by amniotic PCR for detection of fecal infection. Enzymatic immunoassay or immunosorbent agglutination assay, called as ISAGA, should be carried out. If IgM antibodies are present in a pregnant woman, a current or recent infection with the organism is predicted. IgM usually occurs within 2 weeks of exposure to toxoplasmosis, and it can persist for up to 18 months. So remember this. What about IgG? IgG usually appears approximately 2 weeks after the exposure and is lifelong. So if you have any patient who has got IgG positive but IgM negative, you know that she is protected from toxoplasmosis. It's a good sign if she is IgG positive but IgM negative. Toxoplasma IgG avidity test is based on the same principle as that of CMV and rubella. What does that mean? That IgG avidity test, once you do, if it is less than 30%, you know that the infection is less than 3 months old. If it is more than 60%, you know that the infection is more than 6 months old, and that will give a clear-cut idea whether you are looking at a recent infection during pregnancy or remote from pregnancy. Polymer chain reaction examination of the amniotic fluid enables early prenatal diagnosis of congenital toxoplasmosis. Amniocentesis from 16th week of gestation as a positive result would lead to a change from treatment with spiramycin to pyrimethamine and sulfadiazine regimen. Folic acid is added to pyrimethamine treatment to reduce bone marrow suppression. Chorocentesis to detect fetal immunoglobulin, IgM, has been used but has significantly lower sensitivity for detection of fetal infection. Polymer chain reaction examination of peripheral blood or cerebrospinal fluid and urine should be considered. How do you manage? Spiramycin administered to the mother reduces the risk of fetal infection by 60 to 70%. Where primary metal infection is confirmed before 16th week of gestation, it is sensible to begin treatment empirically rather. In cases where amniocentesis is not possible, spiramycin should be started and continued throughout pregnancy with the aim of reducing transmission to the fetus. 36 cases of congenital toxoplasmosis where primary infection occurred in first trimester and where ultrasound findings during pregnancy were normal. 78% had subclinical toxoplasmosis and 19% suffered from chorioretinitis without, luckily, major vision loss. There is no effective vaccine against human Toxoplasma gondii infection. Appropriate information includes advising women about washing kitchen surfaces following contact with uncooked meats and avoiding cat and dog feces. Coming to second in charge, that is rubella. Maternal rubella infection is generally asymptomatic. Mild illness or malaise, headache, coryza, and lymphadenopathy followed by diffuse fine maculopapular rash. Incubation period is around 2 to 3 weeks, and women are infectious from 7 days before and until 7 days after the onset of the rash. It is transmitted through direct contact or airborne droplets from the respiratory system and is contagious. The spread of infection from mother to fetus is by hematogenous transplacental spread. And this is how the person gets this rash. She's infectious when she has got rash. Risk of fetal damage falls steeply after the first trimester and is negligible after 16th week of gestation. Prenatal diagnosis is probably best reserved for infections occurring between 12 to 16 weeks when there is a 55% risk of transmission and 20% risk of congenital rubella syndrome. Affected infants continue shedding virus for at least 6 to 12 months after birth. So what is the sequelae of fetal infection? If it's first trimester, the congenital anomaly includes ocular, cardiovascular, CNS, hearing impairment, and growth restriction. Risk is 38 to 100%. If it occurs in second trimester, hearing impairment, retinopathy, microcephaly, and mental retardation, risk is 4 to 60%. And if it occurs first time in the third trimester, it can cause fetal growth restriction. Sorry for writing IUGR. And the risk is anywhere from 0 to 18%. How to diagnose rubella? By presence of serum rubella IgM, a significant rise in IgG antibody titer. Please remember this. Positive rubella virus culture or detection of rubella virus by RT-PCR. ELISA is a commonly used test. Borderline results from IgG assay can be further assessed by HI test, that is heme agglutination inhibition test, or neutralization test, NT test, or assays available. By presence of serum rubella IgM, a significant rise in IgG antibody titer, you can diagnose this. Positive rubella virus culture or detection of rubella virus by RT-PCR ELISA is commonly used test. I don't know why this has come again. By presence of serum rubella IgM, a significant Then rubella IgG avidity test. Now, what is this avidity test? Please remember this very clearly. Presence of high avidity antibodies indicate an infection which was more than 6 months earlier on. Whereas a low rubella IgG avidity antibodies are found in recent infections up to less than 3 months previously. So, at what period of gestation she comes to you, you will know exactly when she contacted rubella infection, because that is very important from the point of view of congenital rubella syndrome. Now, what is this actually? In the initial period of infection, the antibodies do not attach themselves to this antigen. Please remember this. And that is the reason this problem occurs, and whether it is more than 60% or less than 30% will give you a clear-cut idea whether it's earlier that she got this infection or when she was pregnant in early first trimester, etc., that she got this infection. Intrauterine infection is assessed by IgM assay in fetal blood, which can be accompanied by virus detection in chorion villus sampling or amniotic fluid specimen. By culture or RT-PCR in various clinical samples taken early after birth, and by demonstration of IgM and long-lasting IgG in neonatal serum. How do you manage infected fetus? Dependent on gestational age at the time of presentation, if presented at first trimester, termination of pregnancy would be advisable. Please remember this. Now we can terminate these pregnancies up to 24 weeks. Please remember. So if she comes at around 20 weeks or 22 weeks or so, and you find avidity whereby you feel that she contacted rubella infection 3 months back or so, again, that is the time when you will advise termination. Ultrasound surveillance to identify features of congenital rubella syndrome, specialist fetal echocardiography, and assess fetal growth. Many features of congenital rubella syndrome are not detected by ultrasound. Since 1969, rubella vaccine has been available. And you must give this rubella vaccine to all those women who are rubella IgM negative and IgG negative. Single dose of rubella containing vaccine, like MMR vaccine, is 95% effective in producing lifelong immunity. So if you have a woman who is IgG positive for rubella, that means she is protected from rubella infection. It's a good news. I have seen people asking for rest of the investigation simply because she is IgG positive. That should not happen. Vaccination is the best way of prevention of infection in women 28 days before conception. If she has not taken earlier on rubella vaccination and she is contemplating pregnancy, please ask her to take rubella vaccine before she gets pregnant, at least a month in advance. Coming to third in torch, that is cytomegalovirus. So member of herpes virus species, double-strand DNA virus most frequently passed on to the fetus during pregnancy. And according to American Academy of Pediatrics, about 1% of babies are born with infection, condition called congenital CMV. How does the transmission occur? It's a direct person-to-person contact, whether it is saliva, milk, urine, semen, tears, stool, blood, cervical, vaginal secretion, etc. Incidence is 0.5 to 2%. It's a leading cause of childhood deafness. Risk of serious fetal injury is greatest when maternal infection develops in first trimester or early in second trimester. Transmission occurs in about 80% of cases in third trimester, but it is usually asymptomatic after 27th week of gestation. In recurrent infection or reactivation of an existing infection or reinfection with a different strain, the transmission rate is only 1 to 2.2%. What are the clinical manifestations? The maternal symptoms include fever, weakness, swollen glands, joint stiffness, muscle ache, loss of appetite, and fetal symptoms. 90% are asymptomatic at birth, and then they can develop petechiae, jaundice, chorioretinitis, periventricular calcification, IUGR, hearing loss, microcephaly, delayed psychomotor development, and heart block. CM is a common viral infection. Estimated that 50% of adult population has had the infection at some point or other in their lives. Please remember this. Majority of us have CMV positive. Again, it's a good thing to be CMV positive. When you have IgG positive, you should be happy that you are protected from cytomegalovirus. The virus causes flu-like illness, we already talked. Possible route of transmission includes sexual contact, organ transplantation, and transplacental transmission. Transmission via breast milk and very rarely blood transfusion. What are the diagnostic evaluation of CMV? Serological testing, like I told you, IgG, IgM, and IgG avidity test. Amniocentesis, chordocentesis for fetal CMV. Ultrasonography to pick up all the findings typical of CMV, and whenever required, rarely fetal MRI if ultrasound findings are not clear. What are the sequelae to fetal infection? Congenital CMV infection fetus may be affected in form of ocular defects, including chorioretinitis, microphthalmos, cataract, optic atrophy, sensorineural deafness, hepatosplenomegaly, jaundice, thrombocytopenic purpura, pneumonitis, fetal growth restriction, microcephaly, and neurodevelopmental consequences such as cerebral palsy, learning disability, and epilepsy. Sonographic features include microcephaly, cerebral atrophy, ventriculomegaly, intracerebral calcification, periventricular cyst formation, leukomalacia, fetal growth restriction, echogenic bowel, hepatic calcification, hydrops, and fetal surveillance using serial ultrasound scanning should be arranged. I'm sure you must have seen babies with microcephaly, and as I told you, when she's intrauterine, when you have new biparietal diameter, if the BPD is more than 2 percentile less than what it should be for that period of gestation, well, you know that this is microcephaly. 2 standard deviations below what it should be. And then again, the same thing as in toxoplasmosis, you can have ventriculomegaly, whereby you have the dilatation of the ventricles more than 10 millimeters, intracranial calcifications, hyperechoic bowel, very typical. The bowel is almost having same echogenicity as bones, like you can see here. And when you look at the liver, you will see intrahepatic calcification. It's very typical of CMV infection. And then you can have hydrops. You have the skull totally edematous, and there is ascites also. So you can pick up this very easily when you do ultrasound. Now, absence of sonography finding is reassuring. It cannot exclude the presence of neurological abnormalities at birth. So you have to counsel the patient that even if the ultrasonography doesn't show any effect of this CMV infection on the baby, baby can have neurological abnormalities once she is born. Postnatal neurological abnormalities in up to almost 19% of cases where there was no prenatal sonographic defect seen. How to diagnose CMV? Again, the same thing, demonstration of metal infection relies on ELISA, IgM, and IgG assay, and on CMV, IgG avidity assay. Unlike HI, that is hemagglutination inhibition and neutralization test for rubella, for CMV, there are currently no serological gold standard assays which can be used for confirmation or reassurance. You have to rely on IgM, IgG, and IgG avidity. CMV ELISA, IgM is positive in primary infection, in reinfection or reactivation. Although the strength of reactivity in the test is usually lower, it again is positive. It is usually present within 2 weeks and persists for 3 to 4 months after primary infection. It may persist at low level for many, many, many years. Now coming to IgG, this is usually present after 2-3 weeks of primary infection and is lifelong. Remember this. Again, so it gives you protection. Why I'm saying this again and again for each infection is because I've seen people, when they see IgG positive, they order all rest of the torch infection titer from the laboratory. Patient shells out thousands of rupees when it is really not required. Whilst IgG levels may be boosted by reinfection or reactivation, only a four-fold rise would be considered good evidence of either reinfection or reactivation. Please remember this. IgG going up is not an issue. How much it was, and after 3 weeks when you repeat how much it is to be seen. If it goes up by fourfold compared to what it was 3 weeks back, then it tells you that there is either reinfection or reactivation. Coming to avidity, it's a test based on the observation that antibodies bind less avidly to antigens. Antibodies bind less avidly to antigens during the early stages than in the chronic stages of infection. So avidity less than 30% indicates infection within the preceding 3 months, whilst avidity more than 40% indicates infection more than 6 months previously. So if she comes to you at 4 months and you have avidity, which is higher, more than 40%, you know that she did not get infected when she was in first trimester. She got infected even before she got pregnant. Fetal diagnosis is based on detection of CMV in amniotic fluid. Obviously, that is the only way you can do it, safer way. But CMV DNA by polymerase chain reaction and CMV detection of immediate early antigen fluorescent foci, DEFF, are the two methods of viral detection in amniotic fluid. So this is something which is relatively new. Fetal blood sampling can also be used for detection of CMV or CMV specific IgM, but it appears to have lower sensitivity in detection of fetal infection. How do you treat when the patient has got CMV? Maternal treatment includes intravenous genciclovir at a dose of 6 milligram per kg every 12 hours for a total of 42 days, 6 weeks. The most significant toxicity is neutropenia. There is one more paper that says that you can give 5 milligram per kg for 12 hours daily. And there are others who say that 6 milligram per kg for 5 days in 1 week for a total of 6 weeks. A recent non-randomized study suggested that treatment of pregnant women with CMV-specific hyperimmune globulin may be effective in the treatment and prevention of congenital CMV infection. This has not yet come to us, and I hope this comes very fast in our country. What about management of infected fetus? There are no established prognostic indicators. Role of CMV, glycoprotein B genotype, and CMV DNA load in amniotic fluid remains uncertain. Now coming to next in torch infection, we talked about toxoplasma, rubella, cytomegalovirus, and coming to herpes simplex virus infection. It's a ubiquitous, enveloped, and double-stranded DNA virus from the family of herpes viridae. During pregnancy, the major concern of maternal HIV infection is transmission to the fetus. HSV1 predominate orofacial lesions involving trigeminal ganglia, whereas HSV2 found in the genital lesions, lumbosacral ganglia. What are the clinical manifestations? Will depend on stage of infection and prior immune status. First episode, primary infection, describes cases in which HSV is isolated from genital secretions in absence of HSV antibodies. The present with severe painful genital ulcers, pruritus, dysuria, lots of infection because we all know it involves the genital tract. Recurrent episodes of HSV infection are characterized by presence of antibody against the same HSV type, and the herpes outbreaks are usually mild, remaining for at least 7 to 10 days with less severe symptoms than the first episode. It is preceded by prodromal symptoms like pruritus, burning, and pain before lesions are visible. Mild symptoms are present and few lesions or no symptoms at all initially or for secondary infection. You can see this even the oral, genital, the male and female. What about vertical transmission? It occurs during labor and delivery as a result of direct contact with virus shed from infected sites like cervix, vagina, and perianal area. Viral shedding can occur in absence of maternal symptoms and lesions. Please remember this. Frequency of shedding is higher in HSV2 compared to HSV1 infection. How do you diagnose presence of vesicular or ulcerated lesions, which I showed you? Polymer chain reaction, culture of the viral culture from the site, and direct fluorescent antibody test. How do you manage? American College of Obstetrics and Gynecology recommends that women with active recurrent genital herpes should be offered suppressive viral therapy from 36th week onward until delivery. You can give valacyclovir 500 milligram orally twice a day, or one which we know very well, acyclovir 400 milligram 3 times a day orally. And C-section is recommended for all women in labor or whenever there is a rupture of membrane with active genital lesions or prodromal symptoms such as vulvar pain and burning. SIDS bath to relieve vulvar pain, dysuria, and other local symptoms can be advised. You can give for analgesia acetaminophen and avoid transcervical procedures like cerclage, corionular sampling in women with these genital lesions. How do you prevent? Avoidance of sexual activity during the active disease, use of barrier protection, chronic suppressive therapy to reduce risk of transmission to an uninfected partner, and obviously patient education. I will tackle only two of the others. That is, one of them is parvovirus, which is very important because nobody thinks of this. And when I was at KEM Hospital as a resident, we had Dr. Nitin Chaubal as lecturer in radiology department. We had picked up quite a few cases of parvovirus, and I'll come to that. Parvovirus B19, also known as erythrovirus B19. Virus is a potent inhibitor of erythroid cell differentiation. It is cytotoxic for erythroid precursor cells and can cause erythroid aplasia. Adult infections are frequently subclinical. You may not have any idea that probably this patient has got parvovirus. But if the woman has this sort of a chip, as if somebody has slapped her on both the sides, and how you get that erythema typical, that is what she comes with. There is nothing else. Uh, I don't know what has happened. I think I'll have to join again.
उसके बाहर क्लिक करिए, आपकी
हाँ,
प्रेजेंटेशन के बाहर क्लिक करिए,
वही मैं किया पहले.
हो जाएगा.
I think I'll join again.
हाँ जी सर.
I'll just leave and join.
We are able to hear you, PK, but only thing is the slide is not seen.
The slide was not moving probably.
Yeah, you were able to say the link is all right. Only share screen was a problem.
Sometimes there's problem with the internet.
Yeah. But it is not a total internet problem because I'm able to speak to you, you are able to speak to me.
No,
That
his
means the
internet
link,
problem.
the link
His
is working well.
Yeah.
Link is working.
Actually, these infections are so very much common. And Dr. Asha, you're muted. And
The talk is so good and so simplified. So
yes.
many learning points are there, and it's
And so,
really
and he has very beautifully stressed on important points.
Very
Remember,
good, very
and like
good.
that. So
Very
it's
good.
critical points.
one would like to go through it once again to be
Yeah,
uh,
because in when I did my MRCOG, that time torch infection, people were talking a lot about it, and that time we had a question whether there should be universal torch toxoplasma screening, because in France they were doing, and in UK they were not doing. Because France, they have lots of pets, especially cats are very favorite pets in France, so they were doing a lot. But nowadays, what I'm finding is that in India also, many people are keeping cat as a pet.
yes.
So I don't know how much importance it is, but
Cat has become
yes.
very popular. You're absolutely right.
Yeah,
In
yeah,
US
that's
also a
true.
lot of people are keeping cats
Yeah.
Especially they are less demanding.
Yeah. And they're very clean
I think
otherwise.
he's now back.
Yeah.
PK, you are
Yes.
back?
Yes, sir.
I'm very much back.
Yeah, please go ahead.
Sir, you have to go to slideshow, sir. So at the bottom, sir. Sir, just slightly on the right side.
I can't see it.
I can see it, sir. मेरे को लग रहा है मैं कर दूं. On the bottom, जहाँ पर इससे थोड़ा और right आइए.
Little bit right, sir. Little bit right, sir.
Little right, sir. You are going on left.
Next to the minus sign.
Sir, on the right, sir. On the right, sir.
Bottom right, where you can see 100%, there is a plus and a minus next to the minus sign.
You can't see it because of all these pictures which are there.
Doesn't matter, sir. Just hit F5 on the keyboard.
Go below that. There is a screen size which is less and more. So uske just side mein there is this slideshow.
Okay.
You can just hit F5 on the keyboard.
Sir, at the bottom, at the screen of your bottom, on your right hand side, sir.
No.
On your right hand side, sir,
I can't see this here beyond this because of pictures of everybody.
Just hit F5 on the keyboard. Function 5, F5.
Okay, what do you want me to do?
F5. Yes. Now you just hit down arrow or page down.
I think it's a revision for some of you.
Yes, sir.
You are on parvovirus.
Yeah, there's still a lot of slides to go.
Parvo.
He has to go
You are
to
still in a
torch,
CMD.
Nepris, and after
Move
yes.
up.
Yes,
So
there you are.
B19 infection can cause profound fetal hemolytic anemia, leading to cardiac failure, hydrops, and intrauterine death. A person infected with parvovirus is contagious from 4 to 7 days before the onset of rash and for up to 2 weeks after the onset of rash. Transplacental transmission occurs in 15% before 15th week of gestation and 25% between 15 to 20 weeks, and this rises to 70% towards term. What are the sequelae of fetal infection? Includes miscarriage, anemia, non-immune hydrops, and intrauterine death. Ultrasound technique can also be performed to detect development of fetal hydrops. There is a 9% excessive fetal loss rate before 20th week of gestation. Risk of hydrops is low, 3%, but if it is there, it has a fatality rate of almost 50% in parvovirus infection. Risk of intrauterine death in parvovirus B19 IgM positive mothers is less than 10%. The most deaths occur between 4 to 6 weeks following the onset of maternal symptoms. How to diagnose presence of anti-parvovirus B19 IgM antibodies can be detected 10 days after the infection, but less than 4 weeks, compared with the usual 12 weeks in other infection. You must do it within 4 weeks. Please remember to detect. Parvovirus B19 IgG is usually detectable between 12 to 14 days after infection, provides a lifelong immunity. Again, IgG, if it is positive, gives you lifelong immunity. Parvovirus DNA by PCR is particularly useful when clinical suspicion is high. How do you manage this infected fetus? Fetal hydrops secondary to parvovirus B19 infection can resolve spontaneously in up to 1/3 cases. There is no specific treatment against parvovirus B19. Please remember, serial ultrasound surveillance is recommended at 1 to 2 weekly interval, starting from 4 weeks after the illness, or seroconversion till 12 weeks. And again, I showed you scalp edema, ascites, a very typical picture of hydrops petalis that you see. But what is more important is what is the effect, how much anemic the baby is in utero. And you have to do middle cerebral artery, peak systolic velocity, okay, measurement of this. You can have even liver enlarged like this. Additional Doppler parameters to be evaluated is middle cerebral artery PSV to identify moderate to severe anemia. In a study of 111 fetuses at risk of anemia, an increased MCA PSV had 100% sensitivity for moderate and severe anemia. Fetal blood sampling may be indicated when MCA PSV is more than 1.5 mom, multiples of the median, or where there is ascites or hydrops. Intrauterine blood transfusion may be indicated if the fetal hemoglobin is below the gestational age mean in that particular patient. So that's a very high PSV in middle cerebral artery. Coming to last part of my talk, and that is varicella zoster virus. After an average incubation period of 14 to 16 days, which ranges from 10 to 20 days following primary infection, lesions develop in 3 or more successive waves for 3 to 7 days. Lesions progress through macular, papillar, vesicular, and pustular stages. Fetal varicella syndrome does not occur at the time of initial fetal infection, but is a result of herpes zoster reactivation in utero and appears to happen only when the infection occurs before 20 weeks of gestation. What are the sequelae of fetal infection? Most common symptoms were skin lesions, scars, and skin loss in almost 76%. Neurological defects, cortical atrophy, spinal cord atrophy, limb paralysis, seizures, microcephaly, Horner syndrome, encephalitis, dysphagia. 60% of patients, if they have varicella zoster. Eye diseases like microphthalmia, chororetinitis, cataract, optic atrophy in 51%, and limb hypoplasia in 49%. Risk of fetal varicella syndrome was 0.4% prior to 13 weeks of gestation and 2% between 13 to 20 weeks of gestation. While there does not appear to be any risk to the fetus when maternal infection occurs between 20 to 36 weeks of gestation. What are the sequelae? Key findings on ultrasound include microcephaly, hydrocephalus, limb deformity, fetal growth restriction, and soft tissue calcification. Again, the same thing I showed you earlier on. Hydrocephalus is very, very common in these babies if it is not detected at all. What is important, I'm showing you for the first time, is microphthalmia. If you look at this, the eyeballs, they're very, very, very small compared to the normal. How to diagnose varicella zoster virus? IgM usually appears towards the end of the rash, persists for 3 to 4 months. IgG appears within 10 days and provides lifelong immunity. PCR for varicella zoster virus DNA. Fetal diagnosis can be done by polymerase chain reaction to detect varicella zoster virus DNA in amniotic fluid. Serial ultrasound remains the mainstay of diagnosis. How to manage infected fetus? In case of severe maternal infection, antiviral agent acyclovir can be used for treatment 400 milligram 3 times a day. Varicella zoster virus immunoglobulins, what is called as VZIG125 international unit, used in combination therapy with acyclovir for fetal infection. The confirmed diagnosis of maternal varicella prior to 20 weeks of gestation. A severely affected baby is likely and termination of pregnancy may be offered if it occurs before 24th week of gestation. Now coming to last 4 slides of mine, and I want you to please pay attention that most of us are quite confused about this IgG, IgM and all. If IgM is positive, but IgG is negative, it's a very recent infection. IgM comes into circulation first and IgG comes later on. So if you have done it immediately after suspecting, you may get IgM positive because IgG antibodies come after almost 2 weeks of infection. So that is the first thing. If IgM is positive and IgG is also positive, obviously you know it is an active infection. But IgM is negative and IgG is positive means patient had this infection earlier on and she is immune for almost all practical point of view from that particular infection. If IgG is negative, IgM is negative, but IgG is 4 times or more fold rise, it goes up by 4 times or more, it tells you indirectly that there is a reinfection or reactivation of the infection. If IgM is negative and IgG is negative, you should not be happy for your patient. That means patient is susceptible to that infection. If you have a vaccine available like rubella, please vaccinate her. Now, IgG avidity, if it is low, that means the infection has occurred within 3 months. And if the IgG avidity is high, the infection has occurred more than 6 months previously. Even if you remember this much, I think it's more than enough. So to conclude my talk, ladies and gentlemen, Torch disease is an intrauterine infection and it can cause congenital malformations like CNS, resulting in neurological abnormalities, visual impairment, deafness, in addition to other malformations such as congenital heart disease. Diagnosis is essentially serologically by testing for pathogen-specific IgG and IgM. Amniocentesis should be carried out to test for presence of RNA or DNA by PCR. That is the mainstay of diagnosis of fetal infection in most cases. Ultrasound surveillance is the primary tool for determining the degree of damage. There are few therapeutic options for infected fetus, and these are currently limited to intrauterine blood transfusion in cases of anemia due to parvovirus infection and maternal antibiotics. After advancement in molecular technology, there will be more vaccines available. Further vaccine development may help us to improve pregnancy outcome. Thank you very much, ladies and gentlemen, for your patient hearing.
Excellent, Dr. P.K. Shah. You have walked us through the 4 decades of the ultrasound, which you started in 1982. And you have reminded us the same teacher. And the last but the third slide, IgG, IgM, positive, negative, is the slide which every gynecologist must put up as a display in her hospital whenever she has to talk about recurrent pregnancy loss. Why did I lose my baby? I lost the baby due to a torch. Let her see those things and let her learn. And really, PK, I have been with you for the past 4 decades. I know how much you can deliberate, deliver. And as age advances, your deliberations are becoming more and more perfect, to the point, and more elaborate. I wish God gives you, and we are able to, all Foxians are able to celebrate your 100th birthday. Thank you very much.
Thank you very much, ma'am.
Oh,
Thank you very
Tasha,
much for
boss.
your kind words.
Oh, Tasha, for further comments.
Thank you.
Thank you, sir, for such a good presentation. And you made this difficult topic so simple. And there were lots of things to understand from this talk. One question, sir, I want to ask is many a times you get these patients who have got chicken pox, say around 20 weeks pregnancy. And you do their titers, and the titer are high, and then patient says what to do. I don't want any congenital malformation. Now at 20 weeks, you are really very much worried whether to go for termination or not go for termination. So please guide us a little bit about this.
Now remember one thing, that all these viral infections, all of them do not go to the baby fetus. Please remember this very clearly. How severe is the infection is very important. Because chickenpox, of course, is not that very common now, but it can happen. And the only thing left to you is to do ultrasonography. you do ultrasonography and see whether the baby has any defect or not, and follow her up with regular ultrasonography. So these patients, there is no need to unnecessarily terminate the pregnancy, because all these patients and the relatives, all of them come together, 10 of them, and they sit in your consulting room, and then they say, you give us guarantee that nothing will happen. No one can give guarantee. Even God doesn't give guarantee like that. So you have to explain to them that there are certain viral infections that can go to the baby through placenta. There are other viral infections that can occur in the mother, and they do not infect the baby to that extent, and that we have ways of monitoring the baby. And what would you like to do? Ask them to take the decision rather than throwing decisions on them. And chickenpox is something very common. I have seen the patient comes alone, sometimes because she's worried that her relatives will get infected. When she
Yes.
comes to you, when she's in active phase, and you are also worried whether you will get it or not. But this explanation is more important. I have seen that majority of these, whatever I told you, the infection rate is 1%, 2%, like that. And vertical transmission occurs mainly in toxoplasmosis and rubella, because these are two worst things that can happen. Cytomegalovirus is never a big issue. We have not seen congenital cytomegalovirus baby at all in my 33 years of experience. At least maybe the baby had, and probably neonatologist did not tell us. But nothing very obviously told to us. But rubella, number one, and toxoplasmosis is number two. Rubella, unfortunately, the medication is not going to have much of an effect. It is an eye wash when you give acyclovir and other thing. The latest immunoglobulins that have come is not available in our country. I hope once it comes, we can offer such immunoglobulins to the
Even
patient.
for chickenpox, the immunoglobulin available is, I think, very, very expensive. So you can't just
No,
prescribe to every patient.
no, I think in private, money is not an issue. Whether it is available or not is a big issue.
Yeah.
We have the knowledge, but when you ask the chemist, like we have a royal chemist, which is supposed to be one of the biggest in Mumbai.
Yeah. Yeah.
But
Yeah.
if they don't have, then you don't have to ask anyone else.
Yes. Yes.
It's so
True.
simple. Because they don't have, in 1 year, they don't have even 1 or 2 samples going. So they don't keep it because they are
Yeah.
very costly.
Yeah.
And once they go beyond the expiry date, they have to bear a lot of loss
Yeah.
because it is not used. But how many patients of chickenpox do you see in a year?
So these days we are seeing they are not uncommon.
Oh my
At least
goodness.
I see the three or four cases in a year. So they are not so uncommon, sir.
Wow.
Yeah.
I think you are very lucky that we didn't see so many.
No, I'm not lucky because then what happens once because it was at 12 weeks or so and the titer was very high and patient who said that we don't want to take any risk. So I said, fine, you go for termination. When I said, fine, you go for termination, then they said, no, we don't want to go for termination, and everything went well. But then my decision, I've said, okay, fine, you go for termination. Then they don't, and nothing happened. So these are the cases where you really feel very confused, and you
You
rightly said
counsel them,
that
and whatever is their decision, you
better
write
to take
down in
patient
writing that
in,
the
yeah,
patient, a
yeah,
relative, whatever, whosoever has come,
yeah,
counseled, and they have decided for termination of pregnancy. It
true,
means we already told her that we will do your regular ultrasonography and all this titer and everything to see
yes,
what is happening. But if she is not ready to believe, and if she
yeah,
doesn't want to take any risk, because if you tell her about all this neonatal infection that can happen in utero, I don't think a single woman is going to continue the pregnancy.
yes, true.
See,
It's
I
a
have told you.
difficult situation. Basically,
डॉक्टर आशा तेरा
पेशेंट बोलते हैं कि
डॉक्टर
आप कर लो जो भी करना है, और फिर जब गड़बड़ हो जाती है तो आपको ही जुदा पड़ेगा. So that this is what is.
डॉक्टर
You will take
डॉक्टर
that
आशा there are two
responsibility.
questions in the chat box.
Yeah,
Yes.
please.
Have you checked?
Yes, I've checked.
Yeah.
आप
So
पूछ ले.
आप
please,
बोलो ना.
आप बोल दो ना.
अंजू आप बोल लो.
Sir, one is that somebody's audio actually already covered this. What is the
बोलो
treatment
बोलो.
of parvovirus? वो आपने बता ही दिया सर.
हाँ, we already discussed.
You have already said.
I've seen patients with parvovirus
Somebody
and
has said, please repeat
severe eye
toxoplasmosis
drops.
Yeah,
screening.
okay. Okay, see, parvovirus infection, again, as I told you, all these infections now, when they occur to mother, you never suspect, to be honest.
True,
Let me tell
true.
you, to be honest, it is not suspected. Tell me how many of us have viral infection? So common. We don't get any test done, nothing
Bilkul.
absolutely.
True.
But when a woman is pregnant and if she comes with all this infection,
Eye drops.
tell her that there is a possibility and is it okay if I ask for some investigation, which will give us clear idea whether you have any infection or not and whether it has gone to the fetus or not. Once you say that, she will not say no.
True.
Once you do this, now parvovirus infection, let me tell you, it's basically middle cerebral artery assessment. Because when you're looking at the fetus regularly and you see that there are features of eye drops coming up,
You're late.
scalp edema and ascites and all those things which you know, immediately the first thing you should do is to do color Doppler of middle cerebral artery. If it is more than 1.5 MOM, that means there is a very high peak velocity in that middle cerebral artery. And that tells you that probably the baby has gone into anemia because of parvovirus, because it's called also erythroid B19 virus. Please remember that. If we change parvo into erythroid, again, it will immediately strike us that this has direct effect on the blood production, the RBCs. And once you do that, I don't think you will miss a single patient of parvovirus. We had in KEM hospital 3 patients of parvovirus with hydrops vitalis, and we could save all 3 of them. One of them required intrauterine blood transfusion, but the rest of the 2 patients, they did not worsen when we were doing MCA, and we could manage. But this knowledge is very important. Knowledge is very important.
True.
What was
One
the
more
second
thing,
question?
sir. One more question was, they are asking how frequently should we do an ultrasound for parvovirus?
Parvovirus, I think you
Yeah.
should do it at least 2 weekly.
Okay.
Twice a week.
Sir, one question the other she asked her, she wanted to repeat Troxo, which I would answer that we are going to put a YouTube link of Sir's talk and tomorrow. So you can all listen to the talk once again in details, and I think you will really enjoy it because these kind of talks should be, when you hear them again, you pick up so many points which Sir has stressed. So we are not going to that.
You can put the whole thing on YouTube and
Yes.
people can see it anytime they want.
Yes,
That will help because
at
many
their
times people
convenience.
join late and then they have missed it and they want to
Yes,
know about it. I think it's
yes,
a good way.
yes.
Anything
So,
else, Anju?
but, so thank you very much to you for taking the topic which I wanted so much to be covered because there is so much of confusion in each and every one with when we talk of any viral infection per se, toxoplasmosis
I
and
think many of the
torch.
gynecologists don't know about IgG, IgM. I
Absolutely, absolutely.
see,
So you
I
covered it
see
so beautifully.
complete torch
Thank you very
scatter
much.
ordered when you have IgG positive for say toxoplasma or rubella. That's not fair. That's not fair. Of course, whenever I said that you don't need to do it for a BOH patient, that does not mean you don't do it when patient has some symptoms of viral infection during pregnancy because they are very typical. 2 things which you almost should not miss. One is the rubella. The second is toxo. These
Absolutely, sir,
things you
absolutely.
can at least order and see if they are positive or not. IgG, IgM, minimum.
So especially in preconceptional counseling, because people are really now wanting to come for preconception counseling, and what I feel is that we must do torch in that era, and if she is not immunized for rubella, we must give them a rubella
Yeah,
vaccination.
yeah. I think
That,
that is the best
that
way you can counsel.
yeah, yeah, that is the best way. So that should be given to all the women who are wanting to get pregnant in near future. And I would also like to thank Dr. Asha and Dr. Jayam Kanan for their presence and their insights. Thank you, Walter Bushner, for me being there. Sir, before we leave, I would like Jafar to just give you an online felicitation plaque. Jafar, are you there?
Oh,
Can you
wow.
share your screen?
Yes, ma'am. Yes, ma'am. Sure.
Yeah, please.
तो क्या पोस्ट करने वाले हो क्या?
ये तो मैं शेयर कर लूं।
सॉरी मैम, मैंने शेयर
नहीं,
नहीं किया।
इट्स
मैं
ओके,
कर
नो
लेती हूँ।
प्रॉब्लम यार, खाली मेरे को फोटोग्राफ भेज देना कभी।
नहीं नहीं सर, 1 सेकंड लगेगा सर।
तो वाओ, ग्रेट, थैंक यू। अभी पर्दा खुलने वाला है। हाँ, तो
So on behalf of CCC team, confusion, clarity, and consensus, sections in OBGYN, we are honored and grateful for this opportunity to felicitate and present this plaque to Dr. P.K. Shah, sir, for his appreciation in the field of women health, and his immense contribution has gone a long way in women's healthcare. Thank you very much, sir.
thank you and wish you all the very best for all your future activities and future contests. All your future endeavors, we wish you all the very best. Anju, thank
Thank
you
you,
very
sir.
much.
So thank you, sir.
चलो आशा, मिलेंगे।
जी सर,
हाँ
I
जी।
would also
best
like to,
wishes Anju, and I'm sure you are going to do very well. Thank you.
Oh,
and
thanks.
I also request everyone to wish me luck, and a soft request from everyone to please vote for me as Foxy Vice President, West Zone in 2024. Thank you very much.
All the best, and I'm sure you are going to be a very efficient vice president. So,
Yeah. All
keep
the
going.
best.
All
Thank
the
you,
All
sir.
the
best.
best, ma'am.
Thank
चलो,
you very much.
thank you all of you.
Thank you, sir.
Okay, ma'am, should I end this, ma'am?
Yes, thank you.
Thank you, ma'am.